On this PowerPoint, we're going to talk about coronary artery disease, CAD, and acute coronary syndrome, ACS. Here's the objectives. We want to look at the definition of each coronary artery disease and acute coronary syndrome. We want to talk about the medications for each, nutritional therapies, and diagnostic studies. We also want to backpedal just a little and identify who's at risk and what factors lead up to this. If you can look at this pie chart, now this is probably from about 2017, and coronary artery disease is one of the leading causes of death in this country. A lot of times people are asymptomatic, so they don't even recognize that they have coronary artery disease. Some may develop chronic, stable angina, which we'll define later. The other may develop acute coronary syndrome, which is an umbrella term encompassing unstable angina and myocardial infarction. And these are much more serious manifestations of CAD. Heart disease in the United States kills over almost 400,000 people annually. Every year, about 735,000 people have a heart attack. And of these, 525,000 are first heart attack, but 210 have already had a heart attack, 210,000. And this information is from the CDC. You can always look up information from the CDC using www.cdc.gov. Coronary artery disease, we want to talk about how it starts and its mechanisms. It's progressive. The problem is that it leads to narrowing of the coronary arteries. The coronary arteries bring oxygenated blood to the heart and to other organs. So we're going to see that arteries are on the outside of the heart, perfusing the heart. Because coronary arteries are responsible for oxygen and nutrients to the myocardium, CAD results in a decrease in the supply of both oxygen and nutrients to the heart. If you have too much of a decrease of oxygen, you're going to end up with myocardial infarction. The term atherosclerosis comes from the Greek words athera, meaning fatty mush, and sclerosis, meaning hard. So we've got hard, fatty mush. That doesn't sound too appealing. This combination indicates that atherosclerosis begins as soft deposits and they harden with age. Atherosclerosis can occur in any artery in the body, but it has a preference for the coronary arteries. Some of the things that may lead up to the coronary artery disease, atherosclerosis, would be diabetes, smoking. Diabetes is a disease of the microvasculature. Cigarette smoking will constrict the arteries. This slide here has the pathogenesis of atherosclerosis, and you can see the top one, the damaged endothelium. I'm not going to read each one for you. You can look at these and see how it progresses to the point of D, where it really blocks up most of the artery. There's very little blood flow getting through. This is scary. The process begins late in childhood. So low-density lipoproteins are the chief culprit, and they contribute to the formation of fatty material. The plaque will protrude into the artery, and it narrows the blood flow. Plaque becomes fibrous due to inflammation and healing, so it's a process of getting better, getting worse. When more narrowing occurs, the condition is called coronary insufficiency. In other words, there's not enough good blood coming to the heart to perfuse it so it can do its job. Older adults already have less coronary blood flow than younger adults, so if they have disease, they're already having decreased coronary reserve. You've heard of C-reactive protein. This is an inflammatory marker that's produced by the liver. It's usually increased in patients with CAD, and chronic elevations of this are associated with unstable plaques. You can see here LDL, low density lipids, cause formation of plaque, and then they become fibrous and decrease the diameter of the artery. When you're looking at risk factors, non-modifiable, the things you can't change, when you're looking at NCLEX questions, most of the time they're looking for things you can change. So we can't change our age, our gender, ethnicity, family history, or genetic predisposition. The incidence of CAD and MI is highest among white middle-aged men. After 65, the incidence in men and women equalizes, although cardiovascular disease causes more deaths in women than in men. A lot of that accounts for many, many years, when women presented with chest pain, they were discounted. I'm really proud to say that the physicians I worked with in the ER they didn't discount women. They worked them up just like you would anybody else. So they took their story and ruled out the worst thing first. CAD is present in African American women at higher rates than their white counterparts. So know this too. When answering NCLEX questions, the answer will be typically a modifiable risk. So we're going to look at those in a minute. Here's some modifiable risk factors. All of these can be changed by modifying your lifestyle. So elevated serum lipids, hypertension, tobacco use, and physical inactivity. These are the main culprits. You want higher HDL, high density lipids. So you want that to be better. You want to control hypertension, which is defined as a blood pressure of greater than 140/90 millimeters of mercury, or 130/80 in a client with diabetes or chronic kidney disease. In postmenopausal women, hypertension is associated with higher incidence of CAD than in men or premenopausal women. Hypertension increases the risk of death from CAD tenfold in all people. Tobacco is a major risk factor. The risk of developing CAD is 2 to 6 times higher in people who use tobacco. Also consider smokeless tobacco, so chew. We don't really know what's going on with vaping yet. There's still studies in the works. Things like this do better with a longitudinal study. So in other words, a study that occurs over time to see what the risk is. Remember that with tobacco use, risk is proportional to the number of cigarettes smoked. So for example, if a client comes in and has smoked a pack a day, which there's 20 cigarettes in a pack, and they've smoked 1 pack a day for 20 years, that's a 20-pack year history. But their risk will go up even higher if they smoke 2 packs or even a pack and a half a day for 20 years. So 2 packs a day, they have a 40-pack year history. You multiply the 2 times the 20. The mortality rate from CAD is higher in obese individuals. Obesity is defined as a body mass index of 30 kilograms per meter square and a waist circumference of greater than 40 inches for men and 35 inches for women. Incidence of CAD is 2 to 4 times greater in people who have diabetes, including those with well-controlled glucose levels. The patient with diabetes manifests with CAD not only more frequently, but also at an earlier age. There's studies that focus on specific psychological risk factors thought to increase the risk, and some of these are depression, acute and chronic stress, so living in poverty, serving as a caregiver, Anxiety, hostility, anger are also some factors. Lack of social support. High homocysteine levels found in dietary protein, and that may contribute to atherosclerosis by damaging the inner lining of the vessels and promoting plaque buildup. So you can see here too, modifiable risk factors include metabolic syndrome, increased waistline, high blood pressure, increased blood sugar, and obesity. Risk factors, we just talked about metabolic syndrome. Look at their waistline, measure it, and look at their high versus low density levels in their labs. The key to this is identifying who's at risk. So you take a health history, look for cardiovascular system symptoms, look at their diet, have them do a diet journal, look at their activity, and ask them how often do they engage in activity and for how long. Look at their psychosocial history, history of depression or anything like that, and also look at their values and beliefs. How important is good health to this? FIT is an acronym. It stands for frequency, intensity, type, and time, and this is something you can use to evaluate what your client does for exercise. You want to know how often, that's the frequency. How intense, like is it a moderate stroll, a high intensity stroll? Do they run? Do they go uphill? Do they cycle at 20 miles an hour? Things like that. Again, type, so cycling, swimming, running. Do they engage in a sport where there's a lot of stoppages or there's not a lot of movement, such as baseball? And don't get me wrong, I love baseball. Or maybe basketball where you're up and down the court, but your court time is short. And then you also want to know how long they do this. Do they walk for an hour? Do they walk for 10 minutes? You also want to look at how they eat, what they eat, when they eat, and look at the amount of calories. Get a food journal is one of the best ways to assess this. So you can look at what are they eating, how are they eating, when are they eating, what types of foods, and you may have to do some teaching on good foods, like we see here the omega-3 fatty acids, and they may be a good candidate for a dietitian consult. Just a little word on that. For a dietary consult, you want somebody who's stable, in other words, not an acute MI. That's the least of their problems. You want somebody who maybe is a yo-yo dieter, up and down in weight over the years, lose weight, gain weight. People that take steroids. So, and I don't mean anabolic steroids, I mean something for maybe asthma, COPD, rheumatoid arthritis. Chronic steroids, they need a dietary consult. So these are some of the things. You're looking at here at types of fat and food. It's good for people when they give you their journal, their diet journal. How much bacon do they eat? Every day? Once a week? Once a month? Every 2 weeks? Look at your unsaturated fats. These are good, but the better fats are the polyunsaturated fats that you can see here. The only one I have a problem with is margarine. There's pros and cons on margarine. Some say real bad, some say good. So consult your doctor or dietitian is what I tell the clients. Health promotion. So some of the medications we would give for these conditions, antiplatelet therapy. So aspirin is really a COX, COX-2, the number 2 inhibitor, and it's a pathway in the body. We won't go into very deep detail, but also for antiplatelets, the 2B3A inhibitors, and that's another pathway. So your clopidogrel, prasugrel, ticagrelor, sorry about that. So these are some of the medications. Each one has some black box warnings and they have different nursing indications, and this will be up to the physician. Unless contraindicated, low-dose aspirin is the one recommended for people at risk for CAD, so low dose 81 milligram. When I'm giving aspirin, I always say to the doctor, what's your dose? Because depending on the study you read is the dosage. I wrote an article one time, and while I was reading it, several different articles, one recommended 81 milligrams, so the baby or chewables. One recommended 325 milligrams, and another one 165. So ask the doctor. Some other things that you want to look at, these are some medications, cholesterol lowering drugs, so your statins, bile sequestrants, that would be Questran, Welcor. These bind bile acid in the GI tract, and so they're less absorption. You want to look at HMG-CoA reductase inhibitors. You want to look at cholesterol absorption inhibitor, and also the vitamin niacin. Niacin is something that has mixed reviews on how well it controls. The biggest thing, it says it inhibits formation and secretion of very low density lipids and low density lipids, but it does cause flushing, so be aware of that. Make sure your patient is too. We're going to talk about chronic stable angina. This is different from acute coronary syndrome. Chronic stable angina is reversible. So it's basically not enough blood's getting to the heart for a short amount of time, and the O2 demand is greater than the O2 supply. There's a YouTube here that you can watch on this, and there's plenty of those out there. Just make sure they're from a reputable source. The thing about chronic stable angina, it's predictable. Maybe I get this every evening. Maybe every time a physical stressor or activity, maybe during a walk, if I'm going uphill, I start with chest pain, something like that. The primary reason is insufficient blood flow, and it's going through a narrowed coronary artery due to atherosclerosis. You might see referred pain, so their angina could be in the left shoulder, in the neck, but the key to this is that it goes away. It's transient. It lasts for 1 to 5 minutes. You can sit down and it goes away, and or take a nitro and it goes away. When questioned, some clients may deny feeling pain, but they will describe a pressure or an ache in the chest, and they call it an unpleasant feeling or something like that, constrictive, squeezing, heavy, choking, or suffocating. But the key is that it goes away and it's predictable. Now, if everybody just came in with chest pain that was right in the chest, it would make it so much easier, but that's not true. So you can see that here's some different patterns of chest pain, whether it's stable or unstable angina. So if somebody comes in with back pain that's new and they haven't done anything muscular, it deserves some investigation, particularly if they have risk factors. Look too at the going down the shoulder and the arms, in the neck, in the jaw. So any of these can be chest pain, and we've seen that. So for somebody at risk, even though it looks in the epigastric area, we're still going to work them up like it's chest pain, and then go to, if it's not, then we would go to GI. So the problem is that there's not enough oxygen due to the narrowed arteries, or there's not enough oxygen supply. So some of the things that we do would be short-acting nitrates. So sublingual nitroglycerin. Have the patient or the client sit down, rest. If you're in a clinic or the hospital, you want to take their blood pressure first and make sure they have IV access. If we're out in the community, just have them sit down, take the nitroglycerin. It should be in a darkened little container. Make sure it's not expired. It goes under the tongue. It should tingle under the tongue tongue. If the chest pain doesn't go away in 5 minutes, now maybe it's unstable angina and we'll take a different route. We'll talk about that soon. Short-acting nitrates, sublingual nitroglycerin. So longer-acting nitrates may involve something like transdermal controlled release or the ointment. There's some other medications too that will be long-term, but the big thing that you have to know is that on non-diseased arteries, the arteries are vasodilated so more oxygen can get to the heart, and that's the key. Short-acting nitrates are the first line of treatment for angina. Nitrates produce their principal effects by dilating peripheral blood vessels. So with that dilation, remember the blood pressure is going to go down, so be careful and don't let them get up suddenly. What medication is contraindicated with nitrates? This is a big thing because you should know this one. Erectile dysfunction drugs is something that should not be given concurrently with nitrates. It can cause profound hypotension and even death. So make sure that your client is aware, whether they're male or female. You don't want their partner taking nitro and passing out and even dying. And if your client is a male, you want to make sure that they know not to take one. So, a lot of men will say, well, I might get chest pain during intercourse, so I'm going to take it. And it won't work out. So make sure that you do teaching on that. The treatment for angina and for MI we're going to talk about, this is summed up in the acronym MONA. Morphine, oxygen, nitroglycerin, and aspirin. So this is a good way to remember it. Always check your expiration dates, check your blood pressure, especially if you're giving morphine and nitro together. You want to make sure they should sit or lie down. If their pain doesn't go away, you call for emergency services after the first dose. In the hospital, blood pressure will be checked prior to giving nitro, and you want to make sure that you have good IV access in case you have to give fluids. Typically for nitro, only 3 tablets will be given, and if the pain doesn't go away, they may move on to IV nitroglycerin, which practical nurses would not be given. You want to give oxygen according to hospital policy and provider direction. Not all physicians give oxygen unless the pulse ox is low. For chronic stable angina, here's your management. You want to make sure that their demand drops and that the supply increases. So these are the medications here that you would give. We're also going to do the following diagnostic studies, and you can see those here. You want to make sure that the patient is resting, and if we can increase the oxygen supply by a nasal cannula, that's great. Be aware that the side effects of beta adrenergic blockers, you don't want to give those to people with asthma because it can cause bronchospasms. 3 primary effects of calcium channel blockers are systemic vasodilatation with decreased SVR, decreased myocardial contractility, in other words, we're resting the heart, and coronary vasodilatation. That makes way for increased oxygen supply. So some of the things for chronic stable angina, the physician may or may not have them go to the cath lab. It depends on the EKG and if there's changes. So it's always good if the client has an old EKG for comparison. So we may or may not take them, and there's all kinds of rules and regs that govern whether or not we can give them a stent. So there are many stents that are drug-eluting, so that you have a coating on the stent that has a drug such as Paxil-Taxil or Ceramylase, and these prohibit the overgrowth of the new intima. So they've been very successful, and they've been around for over 20 years. This is what a stent looks like. The stent is transferred via balloon to a portion of the diseased artery. It's inflated and it tells how long on the directions, how long to inflate that particular stent and how high. It's positioned where there's the narrowing, and we'll see those throughout this semester. And then once it's expanded for the given amount of time, the balloon is deflated and the stent stays in place, making way for the oxygenated blood to get through. This is a picture of what a cardiac cath looks like. This one I know very well. It's the right coronary artery. I always like this one because it looks like a C. You can see in picture A the narrowing, and in picture B that's when the stent is put in and now it's got plenty of room for blood to go through. Typically an area must have about a 75% occlusion to warrant a stent, and that's Medicare law. This one is a cardiac cath video and it walks you through the entire thing. Clinical manifestations of ASC, unstable angina. Unstable, obviously there's no pattern, it's not predictable. It may be ST segment changes, usually depressions. So ACS, acute coronary syndrome, is the umbrella term for unstable angina or MI. They're both medical emergencies. Sometimes people have chronic stable angina and their pattern changes. This is worth noting. They need an EKG, they need the doctor to tell us, or to be told, I'm sorry. And we also want to know, how is it changed? Is the pattern different? Does it happen during sleep, during rest? What's different about it? And then they would go to cardiac cath lab. Clinical manifestations of acute coronary syndrome. So this is sustained ischemia greater than 20 minutes. Greater than 20 minutes. Not 10 minutes, greater than 20. You'll see why I'm saying that soon enough. So it causes irreversible cell damage, necrosis. So that area of the ventricle is no longer working well. When we say MI, myocardial infarction, typically we mean the left ventricle. These are the coronary arteries, and this is what a blockage would look like. So you can see here there's a blockage in the left anterior descending coronary artery, and that would cause pain because of the lack of oxygen. And depending on how big it is, and we would go in and measure that, then we would put a stent in there so that we could reperfuse the heart so that it will work well. This is a cross-section of what it looks like, and you can see scarring from a previous anterior wall MI. So basically what happens, the heart can't contract as well. And the degree of altered function depends on how much is involved. So where on those coronary arteries is it blocked? When we're talking about MI, we are also talking about a blockage in those one of those coronary arteries. So the right coronary artery or the left, and the left breaks off into two different ones. There's also some other ones too, maybe a posterior, but this is typically what we're talking about. So we're thinking there's a blockage in one of those coronary arteries that goes around the heart. And most MIs, like it says here, involve the left ventricle. When I saw someone coming in, they would have maybe their hand or their fist at their chest. This is called Levin's sign. And usually when they had that, they were having an MI or at least unstable angina. They describe it in many different ways. Those are some of the adjectives they use. And it lasts, the key, it lasts for longer than 20 minutes. So some of the things that may happen, Heart rate may go up, and so might the blood pressure, but also watch down and see, does the blood pressure go down? It may go down because the cardiac output has gone down. Listen to the lungs. Look at the neck in a 45-degree angle to see if there's jugular venous distension. And listen for anything other than an S1 and S2. These are called S3 and S4. There's a YouTube for this, or easy auscultation. S3, and this is not just me saying this, it sounds like Kentucky, 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 Kentucky. Where an S4, coincidentally, sounds like Tennessee, 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 Tennessee. And that's what the experts all say. Cardiac markers afterwards, the big thing I want you to know here, and there will be a handout that is on the modules, troponin is the one to watch. Troponin. Here's some things for nursing assessment. You already know subjective versus objective data. And for chronic stable, so we're going to go backwards to chronic stable. Here's some interventions. Give oxygen if it's ordered. Make sure you're staying on top of the vital signs, the pulse ox, do an EKG. If they're having angina, they will be on some sort of monitoring device for the heart. And document when pain relief occurs. So typically what I did was do an EKG. Usually there's several people in NCLEX land, of course there's not. But I would make sure they had IV, vital signs and all that, and then I would give the first nitrate, and then if the pain changes at all, I will do another EKG and document on the EKG pain is now 5 out of 10 or pain-free. You also want to keep listening to the heart sounds to make sure that nothing has occurred that's bad. According to the Joint Commission, this is what protocol is. The person should get aspirin, whatever the dose for that physician, upon arrival to the emergency department or hospital or clinic. They should have a beta blocker started within 24 hours unless there's a contraindication such as heart rate, and a thrombolytic within 30 minutes, or percutaneous coronary intervention, PCI, within I think that's supposed to say 10 minutes of arrival. Okay, so basically they're in and they go upstairs. Aspirin or antiplatelet or beta blockers will be prescribed so that the patient will get those prescriptions at discharge. And if their ejection fraction, which we'll talk about during heart failure, if the EF is less than 40%, they're going to be on an ACE inhibitor or an ARB. Don't forget MONA, continuous EKG monitoring, continuous vital signs and pulse ox. Always, always, always looking for any changes. Make sure the person is comfortable and resting. Not a lot of things go on. And believe it or not, cardiac rehab starts as soon as they're admitted. So make sure you know all these things. Make sure you know the time difference, especially for stable angina, which is pain goes away in 1 to 5 minutes, and MI, pain 20 minutes or greater is diagnostic. Here's your references.